So today, the topic of my presentation is on the use of citalopram if the rising use in BC is evidence-based. My disclosures, no conflicts of interests, and here are today's learning objectives. So we're going to discuss why costs of citalopram eclipse that of citalopram in BC. We're also going to review the evidence about comparative efficacy as well as safety. And then finally, we're going to review some considerations for switching patients that are taking citalopram possibly to racemic citalopram. So this graph shows the annual prevalence of use per 1,000 persons for the top 9 most used antidepressants in BC from 2000 to 2022. And this data was obtained from BC PharmaNet records, which include all prescriptions filled at community pharmacies. And this data includes patients older than 19 years old with a diagnosis of major depressive disorder. So since 2009, citalopram use has increased to become the most prescribed antidepressant from 2013 until 2022, and that coincides actually with the decrease of citalopram, which has once been the most prescribed antidepressant from 2001 to 2011. So not only is citalopram the most prescribed antidepressant in BC, it's also more expensive. So a tablet of citalopram 10 milligrams is almost double the price of that of citalopram 20 milligrams. So if 50% of the 55,000 patients that were prescribed citalopram for depression in 2023 were to be switched on to citalopram, we're looking at a potentially $2.3 million saved by both public and private payers. So what are the differences between citalopram and citalopram that might explain the preferential use despite the higher price tag? So the claims that favor citalopram over citalopram include that it's more effective. As well, there are fewer side effects, particularly with regards to the QT prolongation, and that it has a faster onset. And these claims are actually echoed in my pharmacy school lectures, as you can see from the screenshots here. Again, we see more rapid onset, higher efficacy, as well as better tolerated compared to the citalopram. So taking all this information together, the goal of our project was to determine if the claims that prefer citalopram or citalopram are evidence-based, as well is citalopram any better or safer, and finally, is it worth that additional cost? So to help answer our question, we looked at product monographs, as well as US FDA, as well as Health Canada regulatory information, and we looked at international health advisories, and we also looked at a network meta-analysis that compared 21 antidepressants in adult patients with major depressive disorder. So with the network meta-analysis, we identified 12 head-to-head trials that directly compared citalopram with citalopram. Of these 12, 5 were in Chinese, and unfortunately, we weren't able to translate the full studies, and therefore they were excluded from our analyses. Of the 7 studies we did look at, they were all randomized, double-blinded studies with durations that lasted between 4 to 24 weeks. All the studies had a study population of less than 500 participants. Additionally, all studies utilized the intention to treat protocol, which means that all patients randomized, were included in final analyses, regardless if they completed the study or if they adhered to the protocol. And these studies all used something called last observation carried over methodologies, and that's just when the last observation is carried forward and is used for any subsequent missing time points. All the studies included adult patients with moderate to severe depression as rated on depression rating scores such as MATTRS or HAM-D, and then doses ranged between 10 to 20 milligrams of citalopram and 10 to 40 milligrams of citalopram. In terms of outcomes, all the studies looked at change in depression scores from baseline, as well as response and remission. Finally, our critical analyses show that the risk of bias among all the studies were high, and that is due to reasons that include industry funding, as well as incomplete data reporting, along with high withdrawal rates, and no published study protocols available. So the differences between citalopram and citalopram is that citalopram is the racemate, and it contains both the R and the S enantiomer, while citalopram is composed only of the S enantiomer. So does the presence of this R enantiomer explain the proposed differences regarding efficacy and safety between the two drugs? Well, claims regarding superiority of citalopram is based partly on in vitro experiments as well as in vivo behavioral experiments. From the in vitro and animal studies, we see that our enantiomer, was observed to displace the S enantiomer from the serotonin transporter, and that the S enantiomer actually had a faster onset of action. I'll discuss more of this in the coming slides. However, that potential attenuation that is caused by the R enantiomer was not observed in the clinical trials. As well, there is really no evidence that the R enantiomer causes any unique adverse drug reactions. So bottom line, these theoretical differences between the pure enantiomer and the racemate is not reflected in the clinical trials, which I'll go over. So is escitalopram any more effective than citalopram? Both escitalopram and citalopram in the trials improved depression scores from baseline. There weren't any clinically meaningful differences when we compared the escitalopram and citalopram treated groups in almost all of the RCTs. And clinically meaningful change here means the minimal change in depression scores someone would need to experience in order to notice an improvement. So for example, the difference in HAM-D scores between escitalopram and citalopram treated groups at end of studies ranged from 0.3 to 0.9. However, the minimally important difference for HAM-D scores is actually 3 to 5 points. So while both groups improved from baseline, improvements between groups were actually neck and neck, where no group improved more than the other to a point where it was meaningful to the patients. Is escitalopram any better for response or remission? Well, of the 7 trials assessed, 4 studies did not show any statistical differences for rates of response or remission on patients on either medication. 3 of the studies did show a statistical difference that favored escitalopram. However, the reported differences of these 2 studies were calculated to be fragile. And fragility in this case is used to determine the robustness of a trial, and it refers to the minimal number of events needed to change significant results to non-significant. In our case, the number of citalopram patients who needed to respond or remit to lose significance is fewer than the number of citalopram patients who withdrew. So for example, if just 1 patient in the citalopram group did not withdraw and instead actually went on to respond to treatment, that would be enough to change these results to non-significant. And so it's difficult to kind of be convinced by these results as they're potentially not true. So bottom line, not robust. In terms of safety, is it any safer compared to citalopram? Well, this graph shows the percentage of all adverse drug reactions as a fraction of all patients randomized. The rates of adverse drug reactions for escitalopram and citalopram were kind of similar across all studies. Additionally, there wasn't a consistent type of adverse drug reaction that was associated with citalopram that might potentially be explained by the presence of that R enantiomer we were talking about. So bottom line, no consistent finding to suggest that citalopram is any less tolerated. Now, with regards to QT prolongation, Health Canada actually issued an advisory back in 2012 warning about the association of these 2 medications with QT prolongation as well as torsades, and this led to the recommendation of capping doses at 20 milligrams a day for escitalopram as well as 40 milligrams a day for citalopram. In the trials, only 5 out of 7 studies performed baseline ECGs and only 4 studies reported their results, and no study found any changes between baseline as well as end of study ECG measurements, and no incidence of QT prolongation was reported. So overall, based on the available evidence, the preferential use of escitalopram over citalopram is not evidence-based. We couldn't find any evidence that sufficiently supports that in patients with major depressive disorder, escitalopram is any more effective, nor is it associated with fewer adverse drug reactions, particularly with QT prolongation. So taking all this information, where do we go from here? Because I know you guys are clinicians who are prescribing. For patients who you are considering an SSRI, maybe consider citalopram over escitalopram. It's cheaper, the evidence really isn't there. And then for patients who are already on escitalopram, I'm going to pose a question to the audience. When would you consider switching to citalopram? And would you consider switching someone to potentially save money if they had cost concerns? And then kind of looking at bigger picture things, this could potentially lead to policy changes where maybe BC Pharmacare as well as private insurance companies can potentially cover up to the cost of citalopram using reference-based pricing. So that concludes my presentation. Thank you guys so much for listening. I'll take questions now.
Thank you, Dionzie. We'll open it up for questions or comments.
So regarding the Hamilton depression score you showed, so you show a difference of around 0.5, but you said for a patient, it would be around 3 to 5 to tell a difference. So my question is, if the difference is significant, and this is a population level, this becomes just like Dr. Wright's previous presentation that he showed thiazide leads to, for example, very small reduction, but significant in blood pressure. So if you get a difference in depression at the population level, I think logically it makes sense that there's a difference. It might not be at one person, but that was my question. So what do you think about that? If the difference is significant?
Just to clarify, the 0.3 to 0.5 is the difference between, so let's say from baseline to end of study, someone's HAM-D score reduced by 8 points. And then in escitalopram, someone's score reduced by, let's say, 7.7. That's the difference that we were calculating, the difference of change between escitalopram to citalopram. So that's where the 0.3 and the 0.5 come from. For us, we were saying that because that's not enough to really, the studies were small, that's not really enough to kind of reflect a meaningful change. We didn't think that that would relate to any differences between the two medications. Each of the studies had less than 500 participants, so they were small, but I do understand what you're trying to say.
Thank you. Yeah, and just following up, I think the idea with that statistic might be that if you give this drug to enough of the population, there might be one person who has a 3 to 5 point benefit, but you'd have to treat, I don't know how many people to get that one person. And does that justify using it? Maybe that's what they were getting at there. My question is about, you stratified the trials with, some three found a benefit, 4 didn't, whatever. Were all of the manufacturer funding, was it all citalopram that was the manufacturer funding, or were some of these funded by manufacturer of citalopram?
They were all by escitalopram, so Lundbeck or Forest.
I'll just add a comment. The 5 Chinese RCTs, we have partial translations, and more information came in this morning from a student that was kind enough to translate more of it. But this is a summary. If you're wondering why did we purposefully exclude studies that might change our conclusions, and essentially the high-level translations suggest that they are no different than the studies we were able to understand. None of these studies identify any signals that we should pay attention to. And in fact, we're doing an analysis of all racemic mixture isomer pairs that are common in BC primary care right now. And this is the same pattern we've seen with 3 of the 6 pairs that we've analyzed so far, that even in the industry-sponsored trials, if you read the conclusions from the industry-sponsored authors, they don't claim any differences in at least the pairs we've looked at so far. So it's a little bit puzzling why, well, maybe it is a triumph of marketing. Maybe it's not so puzzling. So I take that comment back, yeah. Jill has a question here.
My question is just about post-marketing Torsad or QT prolongation. You guys talked about the monograph. Is there evidence that there are problems later with the cardiovascular risk?
With the health advisory, I think it was because people were using doses like citalopram 60 milligrams to help. And that's when they were seeing when the torsades was happening. And that led to that reduction and capping the doses at the 40 milligrams. I'm not too sure if that has continued with the capping of the doses, but from the evidence. And torsades and QT prolongation, we know, is a dose-dependent response as opposed to a duration kind of thing. So maybe with the change in dose. Thanks.
I can comment a little bit on that. There was a review of observational studies of antidepressants and the risk of QT, and citalopram and escitalopram both appear to cause QT prolongation, but it's difficult with the kinds of studies that were done, but no large signals to suggest one was worse than the other. Any other questions or comments?
My question is about, why escitalopram is used so much. If it's just marketing, I have heard that the private insurance companies that are insuring people who are younger, and that would be a lot of people getting SSRIs, that they tend to favor the higher priced drugs because, in fact, the private insurance companies get a cut or a percentage depending on the value of the drugs that they are covering. So is this true, or is this, in fact, a conspiracy theory that I am unfortunately spreading?
I love conspiracy theory. Absolutely love it, but I have no information to deny or confirm that. Thank you so much, Dionzie.